Good evening, all of you, once again. 96th edition we are in. And today we'll be talking about integrating rehabilitation in psychiatry practice challenges and possibilities. We have a very erudite speaker. You will get his CV very shortly. The meeting will be recorded and available on our Facebook page. The hosts and co-hosts can unmute themselves. The questions are invited in the chat box. Please type in and then moderators will put it up to the resource person. So over to you, Tufan Pati sir. Next slide, please. Dr. Tufan Pati is the chairman of the program. Sir, over to you.
Okay, thank you, Dr. Alim. Welcome to this 96th episode of Thursday Musings. Please mute everyone, and then the.
I've done that. Sir, you have to unmute yourself also.
Yeah. So thank you, Dr. Alim, and I welcome everyone to this 96th episode. Just 4 set up the centenary episode on July 7th, in which Dr. Dinesh Bogra will be the speaker. And we are really grateful to everybody who has participated in this Thursday Musings and made it a success. Now there are Dr. Alim Siddiqui and Dr. Amrit Patudosi, the vibrant moderators. Both are professors of psychiatry and both are young leaders of Indian Psychiatric Society. Dr. Alim Siddiqui is the treasurer of Indian Psychiatric Society, and Dr. Amrit Patudosi is a ISHI member, and he is visible in many fields of Indian Psychiatric Society. Now I have the pleasure to introduce our esteemed chairpersons. Next slide, please. Dr. Ravi Kumar Sharma is MBBS DPM from MBBS and DPM from CIP Ranchi and MD from Nimans Bangalore. He is the director of Chetas Hospital, Udaipur, Rajasthan. He is secretary of Chetas Healthcare and Charitable Trust, Udaipur. His area of interest involves school mental health, primarily adolescent mental health and community psychiatry. Welcome, Dr. Sharma. The other chairperson with us is dynamic Dr. Bibhu Kalyan Shahu. He is assistant professor in the Department of Psychiatry and Disease Medical, Berhampur, Odisha. His additional charge as nodal officer of Integrated District Mental Health Program and De-Addiction Center, Ganjam, and Medical College Campus, Berhampur. Developed module of mental health for paramedical staff training in local language Odia. Developed module of life skill education for high school teachers training in Odia. State level research person for Rashtriya Kishore Swasthya Karyakram, National Mental Health Program and Drug De-Addiction. Played the key role in the state for implementation of NMHP, selected as one of the 10 best practices in DMHP throughout the country by World Health Organization. Welcome, Dr. Bibhu Kalyan Shahu. And with this, without sparing more time, I am handing over the further proceedings of today's webinar to the chairpersons, Dr. Shahu and Dr. Sharma. And please take over.
Thank you, sir. Thank you for such a nice introduction. And I would like to thank, first of all, to the team for choosing this very important topic, psychiatric rehabilitation and clinical practice, the challenges and possibilities. Word rehabilitation, when it comes, there are many different notions in the people's mind. Like, for example, people says that this is mainly for people who are addicted, to put them in rehab centers. Maybe it is for intellectual disability and so on. But psychiatric rehabilitation, when we talk about it, it's not just treating the illness, it's beyond that. So there are 3 terms which are very important. One is psychosocial rehabilitation, other is recovery, and third is psychiatric rehabilitation. Psychosocial rehabilitation is a broad term, and recovery is the basically, from when the patient is treated or the treatment is going on, after that remission is there, from there bring back to normalcy. So psychiatric rehabilitation is somewhere on the road to recovery. This is a very important aspect of this. When I was during my residency, when I was in Nimans, we used to have posting in psychiatric rehab services. There was around 1 month or more. So when I was posted there, I was very fascinated about the way they were dealing the things. So it was multidisciplinary approach interdepartmental coordination, and a lot of the manpower, infrastructure, and other things. But when it comes to the practice, the scenario is different. A patient or his family member, they come to us and they say, "Doctor, our patient is good as compared to earlier problems when we see. But still, there are many things like, will he be able to study further? Will he be able to do any job? Will he sustain in that? And then will he be able to marry? And how we convey this to the other family? And so on. Will he be able to take care of children, offspring? So there are many things. So here the main role of psychiatric rehabilitation comes. So, with this, I would like to hand over to. I would like to first introduce the speaker, our eminent speaker, Dr. V.K. Radhakrishnan. He is Secretary General, World Association for Psychosocial Rehabilitation. He is Foundation Director, CNK Hospital Limited, Changanaseri, Kerala, Chairman for IPS Rehabilitation Specialty, Chief Psychiatrist of Sanjeevani Rehabilitation Center, Chief Psychiatrist at Mother Teresa Home, Member of Psychosocial Rehabilitation Board, Kerala Federation for Care of Mentally Disabled. We are glad to hear from you, sir, and we are willing to see you on this platform, learn a lot from you. With this, I would like to hand over to Dr. Sahu. So please give your inputs and then we can proceed further. Thank you.
Good evening, everybody. Actually, this is a very important topic that is assigned in this Thursday musing. And actually, I'm also waiting what answers I am getting, because I have many questions. Like being a psychiatrist, when a patient comes with positive symptoms, symptom reduction, that is very important. Negative symptom, up to that also something okay. But once cognitive declination comes, then after that, obviously, me being a psychiatrist, for because there is no such scope for rehabilitation, obviously a plateau phase comes.
Okay.
Many questions come to us, just like Dr. Sama was saying, how to rehab them and who after us. Many times people ask us, yes, now we are taking care of our child who is having all this problem, but after us, who will take care? In rich people, they have a separate kind of rehabilitation. They try to find somebody poor and find a partner for the patient with mental illness.
Please stop sharing the screen because you have introduced.
So their marriage becomes a therapy for them, for in the patient's relatives, caregivers' perspective. But in poor people, what for them? There is no scope for them. They search for some long stay home, and where is it available? Now next is, we give some social security benefit. We give some regular amount of 500 or 600 rupees from the SSCPD department, or we give a certificate. With that we give rice and all that. Also employment benefit is there. But at the same time, my question is, how many of them are getting actually rehabilitated by that? This is a big question. Nowhere psychiatric patients are getting job card by this Manrega Yojana. That is definitely somebody will get, who is unemployed will get some employment. People are not getting, although we are repeatedly asking the block development officers to provide some job to them. And most importantly, 50% of the mental health professionals are having RCI registration. So the importance of rehabilitation is very important. That is self-explanatory. But how much we being the team leaders, we being psychiatrists, we have utilized their service for the proper rehabilitation? All these are the many questions that I am having, and all the audience, everyone is having. So I don't want to be a barrier anymore among the eminent speaker. Sir, we are eagerly waiting to hear from you. our solutions, maybe you will provide us. Thank you, sir. Please. Share with all of us.
Thank you very much for the nice words you told about me, and welcome, and Dr. Thopan Padi, Dr. Alim Siddiqui, and my dear chairpersons. It's a great occasion to be a part of this Thursday musings because Dr. Thopan Padi, we have our acquaintance for last 4 decades nearly. So we had a very close companionship as well as very close friendship for such a long time. Actually, our relationship started with rehabilitation only. And he visited Kerala, and there is a Kerala model of rehabilitation. There are so many rehabilitation centers in Kerala. Dr. Thopan Padi spent nearly a week here and visited more than 100 centers here. And we traveled all over Kerala with Dr. Thopan Padi. And still, Thopan Padi is a very VIP guest for all these Kerala rehabilitation centers. So when Sari Soku will organize such a program, I had a great passion to participate in this one, because last few months I was busy with the WAPR international elections and I was elected as the Secretary General. For that, frequent meetings used to come in waves, so I was not able to attend his calls. So I apologize for that. And with that, we will start this, because when Dr. Thopan Padi make a request, I cannot deny it, because only because of this situation, and I was not able to fulfill it. So at this occasion, I am getting a chance to be a part of this Thursday musings, and it's a great thing. And so many people around the world used to tell about this Thursday musings, and everybody now knows that what is going on here. It's a very good academic exercise for such a long time, and even it is reaching to hundreds, and it's going to complete the century. It's a great thing. I think first time in India, the history of Indian Psychiatric Society, such a initiative is taken by a group of people and who is doing it excellently well. I congratulate all these people who is involved with the Thursday musings once again. Then regarding the rehabilitation, actually the question of rehabilitation came when the chronicity was a big problem. The psychiatric patients, we all treat psychiatric patients, see psychiatric patients, and the concept was once a patient, always a patient. The worldwide, after the UN Declaration of the Human Rights in 2006, following that, there was a lot of steps taken in the different parts of the country to improve the human rights. Especially, they are the most downtrodden people regarding human rights and personal rights were women and children. And like that, when it comes to the medical field, it was our poor mental patients. Their rights were not addressed by anybody. And once they landed up in a mental hospital, they stays there and they dies there. And the rehabilitation message was going on there was the work done by the, supposed to be done by the paid staff. They used to utilize these people for their work. Actually, the rehabilitation was nil. But still, if you go back to history, the rehabilitation was conducted in CIP Ranji long back. And there is history and a record is there. How what was the price of one ratal of when that was the measure at that time, not kilograms. One ratal or 1 pound of aloo, the price of 1 pound of aloo, 1 pound of tomato, they're all recorded in the CIP. And because they had a very great, good area, and that was cultivated at that time. And subsequently, then that has faded out. And then NIMHANS taken a lot of initiative, and PS Gopinath came into charge of this rehabilitation, and he started so many things. And Dr. Murali, he has done a lot of work in this field. Then regarding the rehabilitation, when the rehabilitation starts, we should always remember the rehabilitation starts from the first consultation. Whenever a patient comes to you, the first time, the rehabilitation you have to think of at the first consultation itself. Our main aim is to send back the patient in a normal functioning manner as early as possible. So reduce the admission, send back the patient, and then let him do or work in the same field which he was working. In India, once you come to our Indian scenario, and I would like to recall one Nobel orator who came to Kerala some few years back. Then he was with me for 2 days, and he was Christopher from United States. And he was telling me, Dr. Radhakrishnan, you have to tell your people that they are like to copy us from the West, but they should be careful about the integrity of the family relations in our country, because that's a great thing which we are working on. But why schizophrenic recovery is more in Indian setup? Why mood disorder people is getting better by go by to work more in India? Because our family setup and family link is so tight. Even now, the majority of the mentally ill people are cared by family only. Then the sustainable development achieved only by inclusion of mental health, a global priority. So that's coming up, especially WHO has taken it in a big way regarding the quality rights, and they are planning to train millions of people in the next 2 years. And Dr. Murali has already attended that training program. I think the through IPS, we have to, everybody of the members of the IPS should get trained in the quality rights and online training program. Then the economic cost of mental disorders is calculated to be 4% of the GDP worldwide. Depression is the leading cause of disability, which was already confirmed. Then sustainable model, the cost effective, especially the developing countries. When you are talking about the developing countries, a lot of things are there, because I was the chairman of the committee to form guidelines for rehabilitation in Islamic countries. There we visited the low cost or low income countries and found that the situation is even bad than our situation in many parts of the world. So the cost is very important. You cannot copy down a typical Western model to these places. Then globalization, that is coming in economics, commerce, social science, and psychiatry. Then 6th August. I think as psychiatrists, we should, more than August 15th, we have to remember this date, August 6th. What is the importance of this? All you know, that was the day when the Yerwadi tragedy took place. So that was a shock at the face of the Indian psychiatry. 26 people charred into death in, chained people charred into death in Yerwadi and in Tamil Nadu. The situation was created a lot of agony all over the world. And we have to look down and we have to bend our heads in front of the world in that occasion. So following that, what happened? What is going on in Yerwadi? Yerwadi is a religious place. There, psychiatric patients all over the country used to come and get admitted, and there's one dargah is there. The chain which is has undergone puja in that dargah, and the patient is chained with that thing. So they cannot move. And it was some thatched sheds. Suddenly, somehow, how it happens, even now, even today, we don't know. And the whole thing has got fired, and 26 people charged death, and the Supreme Court, Apex Court has taken it as a suo motu petition, and they directed all the governments to implement 1987 Mental Health Act as soon as possible. Then the rehabilitation centers, then the guidelines came how to form a rehabilitation center. Their registration, admission and discharge, infrastructure, training, work areas, staff pattern, and conduct of rehabilitation work and monitoring. Then Karnataka mental health rules came after that. Acute care, rehabilitation centers, halfway homes, sheltered workshops, separate headings. Tamil Nadu separate rules, Kerala separate rules. Then the requisite of a rehabilitation center in these places are application form duly filled by the to favor the competing authority, recommendation by the inspecting officer, certificate of registration. These are happening in so many states now. Then standards prescribed for infrastructure, building, and then rooms, dormitory, and distance between two beds, etc. Then residents shall provide with adequate work area, adequate materials, simple and safe work, and adequate remuneration, and work training should help the resident to regain the mental balance. Then prescribe visit of a psychiatrist, full-time social worker of psychologist for every 20 residents, 1 attendant for every 10 residents. Then standards prescribed in conducting rehabilitation work, allotment of professionals on admission, then attendance on duty will ensure the medication and caring of personal needs, maintenance of case records, adequate facility, and should follow a healthy daily routine. Then there should be a committee of visitors consisting of eminent psychiatrists, social workers, and have rich experience. The inspection and submission of report every month by not less than 2 members of the committee. Then for residents, every resident should be informed the purpose for which he or she will be admitted and their consent to avail the service, rights of the patient to be preserved. That's very important. Confidentiality to be maintained. Even that our new Mental Health Care Act 2017, that is very well appreciated all over the world only because of the chapter 5, because the rights of the person with the mental ill. Violation of the human rights is a very, very strict thing now. Then rehabilitation center services are medical services, assessment services, then psychosocial services, and supportive services. Medical services, then qualitative diagnostic and treatment prescription, then periodical clinical evaluation, then administration of medication and allied physical intervention. Then assessment service, as you know, disability assessment ideas, that's another one of the very important achievement of Indian Psychiatric Society. We were able to develop a tool which was developed by Dr. Murali and his team and Mans and from Chennai also. And it was accepted by the government and gazetted, and that is still following in our country. Then psychosocial services, casework, as you know, the social skills training, behavioral therapeutic intervention, occupational therapy, recreational therapy, horticulture therapy, bibliotherapy, and vocational training. Then behavioral principle. That's the main thing in which we are using in training the people. Occurrence of a particular behavior is increased if an unpleasant stimulus, a pleasant stimulus, reward following the behavior, a positive reinforcement. If an unpleasant stimulus removed following that behavior, that is negative reinforcement. If an unpleasant stimulus following a behavior is punishment, if a pleasant stimulus is not given, is an extinction. Then method of increasing desirable behavior, reinforce, reward immediately at the beginning, do it consistently. State clearly which behavior is reinforced. We should have a good rapport with the patient and make him understand what we are going to do with him. Combine material activity and reinforcement with the social reinforcement and gradually reduce material reinforcement and training is achieved. This is a long process. Then shaping of the behavior to begin with the existing behavior which is to be reinforced. Especially for an example, if the patient is having a poor eye contact, how we will develop that eye contact? For that, if you talk with the patient and the patient gaze will be downward and he will not look at you. Instead of that, you can keep an edible thing. Suppose a laddu near the eyes. The patient will look at this laddu. Then gradually, with a few sessions, he started looking at you also. And after this training, give that laddu to the patient. Next one. Then
just a minute, please. I think I am not able to visualize the screen. No, the white background is there.
So the screen is large actually.
You have to zoom it.
Zoom out.
Down.
Yes, sir.
Is it clear now?
Sir, a bit smaller. A bit smaller. Make it a bit small. Are you playing it full screen, sir? If you
No.
make it full. So actually, the font is too big, so a part of it is being trimmed out.
Yeah, I'm not saying. Can you send it to me? I shall get it shared by the support staff.
Okay, okay. I'll send it afterwards.
Yeah. Okay.
So now is it visible?
No, sir, it is out of center. Out of center.
Yeah.
Not visible. Are you able to see it?
No, sir.
You can stop sharing and reshare.
Okay, I will share the slides.
Yeah.
You stop the screen share, sir, and then share it again.
We are seeing the your wall, your face.
I think this one is still better.
Stop sharing.
Is it clear now?
No, sir, you have to screen share it. The screen is not being shared yet.
We have to
Start
again
screen
share. Again share screen.
It is
Yes.
coming on now, the later slides.
Yeah. Yes, no, it's okay.
Yes, yes. Good. Yes, sir, it's good now.
Okay. Yeah. Then and prompting, teaching eye to eye contact. That's why I told you. And the patient, actually, the patient with negative symptoms, it will take a lot of time and days to weeks. So we can keep the laddu at your eye level, and the patient will not look at you, but he will look at the laddu. That you can continue for some time, and after that session, give that laddu to the patient. So he's giving a reward. Then look at me facing him, use an edible reinforcer, holding at eye level. He looks at reinforcer, automatically looks at the therapist. Then complex behavior, we have to divide it into small pieces. Complex sequence of behavior, broken into simple steps, and one act, one reinforcer. You should be very careful about this thing, and don't be in a hasty manner. You suppose if you want to give a pen and make him write, and first holding that pen itself may take days. Then start writing. So we have to do it like that and consistently with patiently with our patients, and we should wait for hours to develop, get its attention in this field. Then another decreasing undesirable behavior. That's also after discussion with the patient. You can, there's a timeout, response cost, overcorrection, etc. Then suppose the first thing is about the development of personal hygiene, which we can do all these things in spending 5 minutes in the consultation room from the first visit onwards. Suppose a patient with the negative symptoms and maybe a wandering lunatic coming to our consultation. The first thing about personal hygiene is brushing teeth. That we have to start with picking up toothbrush, taking paste, holding the brush in right hands, apply toothpaste, then wet it, placing the brush in the mouth, brushing the teeth up and down, circular motion, a few minutes, then rinsing the mouth, cleaning the tongue, washing the face with water, wash toothbrush, then close eyes, wash the face with soap, wipe the face with a clean, dry towel. So this we have to continue for days. On first day, if he gives brush and paste, he may just push it whole paste in and may just apply on his stomach. May happen. Then by holding that brush, we can develop these things usually within a period of 6 weeks training. Next one, the supportive service, family guidance, counseling, and family therapy, and family education program. There are separate modules available nowadays regarding the family training program, because family support, as we are having a lot of family supports in Indian situation, still some of the family members have a negative feeling towards this patient itself. So we have separate family sessions, and we have to use family therapy techniques in these things. We have to found there is some family schism or skews, such things, and involving the whole family members in the treatment program, that will create a real change. As the rehabilitation center which we have in our place is known as Sanjeevani. There, I am working with that center for last 29 years. Initially, we used to have a revolving door policy of admission. Patient will come, stay there sometime, again he will go back. After 3 months, again he will come back, like that. After that, in 26 years back, 25 years back, I started a program. We used to have outpatient sessions on every Friday. So I used to insist that the patient should come with the family members. Then we'll have a separate meeting for family members for half an hour. In that, I used to take class, explain the psychiatric symptoms, explain the psychiatric disorders, and what's the importance of treatment. How can family members avoid triggering points in patients and daily behavior? And found what the result was. Astonishing result came after one year. The revolving admissions came down to 30%. Only because the family members get aware of these things and the medicine become regular, and the patient's readmission rate was reduced like anything. And I have presented this paper in Malaysia, and people appreciate it very well, because that's psychoeducation program, how we have to integrate with the family members. Even Kerala is one of the literate states in the country, and but still, most of the trained people, even people with MSc or MA qualification, their knowledge about psychiatry and the mental illness is very, very, very negligible. So we need public programs and create awareness. And Dr. Thopanpadi may be recalling the public meetings we addressed during our visits in Kerala. Then linkages with the government and community-based agencies. The government sectors, NGOs, and corporate sector, they all are operating in the field of rehabilitation. Then government sectors availing grant assistance from Ministry of Social Justice and Empowerment, Ministry of Health and Family Welfare, and National Trust, and technical know-how in developing infrastructure as per the guidelines. Then after that, brushing the teeth, the next step we have to take is bath. taking bath. For that also, they need a training, how to pour water and how to apply soap and how much time they have to wait after applying soap, then how to wash it off, then how to wipe it out with a dry towel, and how after the bath they have to take fresh clothes and wear fresh clothes. Next is promoting and formation of self-help groups, awareness or generation programs through conducting mental health camps and involving community participation. Community participation is very, very, very important because the stigma, the eradication of stigma will attain only with the education of the community. And we have to make them understand that they are also a part of the treatment program and they have the responsibility to help their brotherhood. And like that, then we have to create an awareness in them, and the psychiatric problem will develop to any patients at any time. And after developing such a problem, how we handle it and how we will bring him back to the normal level. Then corporate sectors and voluntary forums are there. Then social disability, withdrawn, hostile, no financial responsibility, overspending, poor interaction as a partner, poor and emotional sexual behavior. So here, these are the usual things which we are seeing. So when we are training the family members, this hostility will gradually reduce. Then giving patients small financial responsibilities like that, he will get trained for that. Then social disability, social activities like festivals, marriages, parties. And another thing which I want to mention at this time, there's a rehabilitation center in Calicut, North Kerala. There, it is run by a retired superintendent of mental health center, Calicut. What he was doing that, this rehabilitation, this what happens, every marriage is taking place in that village. After the marriage, they send the remaining food to the rehabilitation center. And after 2-3 times, this doctor and the inmates, they are having 80 inmates. They take a decision in their meeting that we don't have the carryover food after this function. They put a suggestion. And any marriage or any function, they can invite, they can give an invitation to the center. And they will select 3 or 4 people, and they will send them there. They will go and attend the marriage and comes back. This was the best model of socialization. And they are doing it successfully for last 10 years, 10 or 11 years. And now they are getting a very warm invitation from these places, and they are going there and doing very well. They are participating in the marriage function, and then they will attend the feast very well, and they are coming back. So this is not mentioned in any of the Western textbooks. You can't find such things. This is a innovation of a common man. Then social activities, then objectives of rehabilitation. Bring back the patient to the normal life. That's the. Then again is occupational therapy. That as P.S. Govindath mentioned long back, some 40 years back in NIMAS, I still remember his class. He always says that occupational therapy is not hospital work. The hospital, in most of the places, most of the mental hospitals in the country, the occupational therapy is sharing or substituting the work supposed to be done by the staff. That is not rehabilitation. Even 60 years in India, diversion of morbid state, tension, anxiety, aggression, and confidence, recognize right and wrong, channelize psychomotor activity, satisfy emotional needs, and social approval. These are the things which we have to look at. Then Kerala, highest literacy, increased awareness, density of psychiatrists is very high, inpatients beds are high, medical college and mental hospital, government hospital, private hospital include more than 2,500 beds, and demand is also high. The WAPR initiative. WAPR is World Association for Psychosocial Rehabilitation. And when Dr. Murali was the secretary of National Secretary, and I was a board member at that time, and we have conducted a workshop that is long back, and conducted a workshop in 3 days workshop in Ernakulam. Then lectures on causes of mental illness, broad categorization. These centers were run by common men. They don't have any training in psychiatry or psychology or social work. Their investment was their humanism and humanitism and brotherhood. With that, they have done this. The lectures taken by the eminent psychiatrists and psychologists and psychiatric social workers. Then we highlighted the drug therapy, other therapy methods, and rehabilitation techniques. Then activity scheduling, Mental Health Act 1987, and other legal issues. Then second day, post-workshop assessment was also done. Initially, most of these places were only prayer groups. They were having only their prayer, and they used to pray the whole day with songs and all these things. But then with that, we were not involved with their prayer. Let them continue that. With that, the patient should be given medication, and the patient should be given seen by a psychiatrist. After consultation, the medicine should be started, and it will be prescribed and it will be given in a regular manner. Then these places, they accommodate 9 to 220 people in different Sundays. And all of the patients are picking up from streets and brought by police or social workers, and few by relatives. Age distribution varies from 15 to 75 years. Then permanent buildings, plenty area of 1,500 to 10,000 square feet. Some big Sundays were also there. Then professional acceptance, support, and actually the psychiatrists were turning away from these Sundays at that time. That it was a model of the country, low cost, that they were, our community was not accepting this at the beginning. I am talking about this some 25 years back history. Then UNCRPD, United Nations Convention on Rights of Persons with Disabilities, 6th December 2006. Then rehabilitation. Then we formed after this Airbody tragedy, what happened? The government asked to close down all these centers, which catering care for more than 12,000 people in the state. And suddenly, we involved, Dr. Murali and myself, we involved, and we had a meeting at the Secretariat, and then Minister Sri Shankaran and Sri T.M. Jacob and the Health Secretary, Superintendent was there. Then they formed a committee under the chairmanship of me, and they formed a committee, and we submitted a report. Myself and Dr. Jairam was the members of the committee. Dr. Jairam was the then superintendent of Mental Hospital, Trivandrum, and he is no more. Dr. Thopanpadi was very close with him. Next. Kerala, then Kerala government accepted and gazetted as the Kerala Rules 2012. These are the some programs which is attended by this a group of students from Singapore. They came and stayed in this center for 2 weeks, and they learned how we are doing the rehabilitation, and they appreciated it very well. Then this is another function which is inaugurated by the Supreme Court Justice Kurian Thomas. These are the students from that. This one of our close friend, Dr. Faisal. He is running a rehabilitation center near Trichur, Chavakkad. And actually that group, they are employing the psychiatry ill patient. It was run by a big group, Raja group, and most of they are having 7 directors. The security staff in all these directors, residents are recovered mentally ill people. And there is a funny and interesting story was there when we visited that place, and myself and Murali, the director of that institute, was telling. And one day he brought a new Porsche car, and the security, they were so-called people, psychiatric people, they were not knowing this car. And when this car came, they were very anxious, with apprehension. One person climbed on the gate, and he fell down on the bonnet of this car. They were that sincere, and they were given full salary. Next one. Then this is a meeting which we attended there. Then this is another thing which is inaugurating by our Dr. T. Murali, and you can see another person who is standing near to me is Colonel Goyal. He was the then advisor to the Prime Minister of India. And we are inaugurating a bakery and run by the rehabilitated mentally ill people. This is a special Kerala preparation known as Kinnanappam. Dr. Murali is inaugurating that. This is another function where it's conducted in Maria Southern Rehabilitation Center in Pale. This is our great leader, Sri P.C. George, inaugurating. He sounded very much for this mentally ill people. Only because of his initiative and Sri K. Mani's initiative, that rule came into shape. This is another meeting. The slide which I shown before, that meeting is a special meeting because we formed an orchestra group in Pala, Maria Southern. One day, myself and Murali, when visited there, the people, the admitted people, the inpatients were singing songs. Then Dr. Murali asked them, why can't you form a orchestra team here? And then they started working on it. And when they started their first program, arranged in Todupuja near Pala, but the orchestra, when the singers were ready, the orchestra team or the violinists and all these people refused to be a part with the mentally ill people. From there, we worked on it and we trained the separate people, and this group completed 250 stages with in past paid programs like that came into Limca Books of World Record. That is a great day for the rehabilitation of the country. This is another meeting which we conducted in Nepal. You can see our famous psychiatrists are here. Dr. Mohandas, our past IPS president, is there, who has done a lot of things for rehabilitation here. And Dr. Murali is also there. We traveled almost every part of India. Even we were there with Orissa also with our boss, Dr. Thopan Pavi. The previous slide, which we showed one because they are having a regular visit to the villages. And they have got a full team, one psychiatrist and one pharmacist, one nurse, and a social workers. And they used to go to the villages and distribute drugs for 1 month. This was donated by a businessman there. Then conducting carnivals to share the research findings with the family members. Publishing booklets, information sheets, and quiz programs, and the church program and the temple festivals are there. In between, we used to have a cultural program like drama or orchestra or Ganamela and all these things. In between that, we used to have a 10 to 15 minutes talk about psychiatric illness and rehabilitation. That used to be clicked very well and people appreciate it very well. Then this is another meeting conducted in Alappuzha, near the coastal area, and it was well attended by hundreds of people. And all these people are very keen on the care of these mentally ill people. This is another meeting of the GRACE. That means an organization run by the relatives of the patients. So here we can see the left side, one priest, Christian Catholic priest, who is running a rehabilitation center. The next one is the most important person for us, Justice K.T. Thomas, who took the sumo moto case in the Supreme Court during the Yerwadi tragedy. Another one is Bishop, then Dr. Murali is there, and Dr. Roy is there, and Santosh Joseph is another person who is running that center. I was inaugurating a program there. This is another MLA and Bishop is inaugurating another program in another place. This is also another program. This is another thing. The St. John's umbrella, Poppy umbrella, these people are interested in their work with this rehabilitation centers. In Moolamata, there is a hospital known as BVM Hospital, and they were given a decent salary for that. So the finishing work will be done by these people, the famous Poppy umbrella. This is communities. This is an example for community support, and they can have a local sales for that. Then this is yoga training, which is doing almost in all centers. Then after that, we are distributing some space. There is Wayanad meeting. Wayanad is the northern district of Kerala, where a lot of work is going on with this thing. Actually, the first meeting of the Kerala Federation has taken place there in 2003. From there onwards, this our long journey has started, you can say like that. Then this is a rabbit farm, which is conducted in another rehabilitation center that's running profitably. So whenever you are planning a program, rehabilitation program, it should be sustainable and it should be feasible. The things which we are making there should be having demand in the local area. You cannot export these materials. You have to sell it in the local area. So we have to plan it like that with a proper homework. Then the recovery, as our chairpersons mentioned in the beginning, the recovery is a very important thing and the most discussed thing in the present world. A desire for recovery. Every patient has got a desire for recovery. Even every family and had a desire for recovery. Then their independence, their employment chance, lot of chances are there. Then education, friendship, recreation, spirituality. Then I had a patient who was 25 years of age who had a very frequent attacks of mania like that, and he was treated. And I asked him to start a small business by getting 5 kgs of chili and get it powdered and make it 250 gram packets and sell it to his neighbors. This has happened some 6 years back. He started with that. And the next time he was with that small profit, he was able to get 10 kgs of chili like that. And this is some 8 or 9 years back. Now he's running a flour mill with now he's doing the work of 10 bags of chili every month. And he's having his own family and doing well. So this is also the meetings. Then this is a patient who was picked up from the street and now his condition is like this. This is in Marayur and near Wayanad. This is another function conducted by our Ram Subramaniam, who is doing a wonderful work in rehabilitation in Tamil Nadu. And he was a nodal officer and he was the person who changed the plight of Yerwadi. And now he is running regular clinic in Yerwadi, and Yerwadi is moving in a more scientific manner. The credit goes to Ram Subramaniam, none other than Ram Subramaniam. He's a great person in that field and doing a great work for this hopeless people. So these are the things. This is a science thing which happened in the great flood in Kerala last 2 years back. That the person is waiting for the boat to come. The whole place was drowned like that. Now he's at the top of his house. So with that, rather rehabilitation, if we are able to rescue that person who is mentally, suppose he is mentally ill, and he is sitting on that small place when surrounded by water. But I am sure we can save him. We can bring back to normal life. We can save every psychiatric patient. We can save every schizophrenic patient if you do a systematic rehabilitation. So spend at least 5 minutes in your consultation time for rehabilitation. You can do wonders. And this we are doing for whatever work we are doing for this helpless patient. That's a divine work. We are doing for God. That's a prayer. We consider it as a prayer and do it. And I grab 5 minutes of your consultation time for rehabilitation. Hope everybody will agree with that. Once again, I thank everybody. And Baba Dopanpadi, thank you very much. Ali Siddiqui, our chairpersons, Bibu and R.K. Sharma. Thank you very much. It's a nice time to meet you all people. And I have a request to you people to take up rehabilitation and do something in rehabilitation in your area. Okay, thank you very much.
Sir, can you switch off your PowerPoint, sir?
Okay.
Thank you, sir.
Thank you, sir. Over to chairpersons for their opening remarks.
Sir, I am before giving the conclusion. I think I'm having three questions which I want to ask, sir. Sir, one thing is that although as you said, the rehabilitation starts from the first consultation itself. But generally, what we say, what we see generally, the treatment is one, we take the remission, and then from there we start another story. But if we see from policy wise, the one part of the same journey, the treatment part, is dealt by the Ministry of Health and Family Welfare, and the other part, when we see of rehabilitation, this is dealt by Ministry of Social Justice and Empowerment. So my question is, does it really means this difference in two different policies by two different ministries, does this make a difference, or is there another way later ahead? How can we go? The second question is the role of media. Many times we see how the media is portraying the suicide or other mental health issues or mental illnesses. From there, it starts copycat phenomena, and then it again increases the stigma, which is very important barrier in road to recovery. So how the role of media can be enhanced to overcome this and to improve the rehabilitation process or road to recovery. The third one is about the religiosity. We know, as you said somewhere, something how the treatment part is incorporated into the religious beliefs as well at the same time with prayers. What earlier I think I read about Dawa Dua project as well somewhere, how they are doing. It started from Mehsana, from Gujarat. So, but people have enormous faith in this religious beliefs, and that there are too much religious belief. I don't know how the religious leaders they talk, also how they talk, and sometime I personally feel that it prevents rehabilitation, increases stigma, and again increases chances of relapse. So how that part also, how we can deal. So these are my three questions. Just it came into my mind.
Okay, thank you very much. Very good questions. And these are the usual apprehensions carry over by our people for a long time. These are very important things. The first regarding this two departments and the ties and the problems between these two departments, that's also a big problem. As I like to recall the Vivekananda's Chicago speech, and he told the Europeans, in Sanskrit, we don't have a word, exclusion. The exclusion is not in Sanskrit. As Indians, we don't have that word exclusion. We are not excluding any departments because this type of the quarrels and rift between departments are there. With that, we can involve both of them. Why this rehabilitation become a social welfare part? Because some of these things which are taken care by the social welfare departments is work very well. And another thing is regarding the Mental Health Care Act and the Health Department. And in few things, we have to come to a compromise. I think with the roundtable discussion, we can manage these things. And Dr. Murali is knowing that we had these problems in Kerala in the beginning, but we were able to handle it to some extent. Then regarding this religious problem, see, the greatest thing, latest flickering and firebrand thing in our country is religion. We should be very careful when you are addressing this question. And even in this talk, I should be very careful in using the words, each words in answering this question. Because the religion, everybody has got their own, and considering their faith as big, and their outlooks are correct. And that's the only way to get salvation. And like that, everybody preaches. We don't interfere in these things. We accept this. If they are praying, suppose they are putting water from morning to evening, okay, agreed. That's a good thing. Okay. With that, put some medication, some tablets in his mouth, then you do pour water again and again. No problem. We don't have anything against you. We are not against this. And even if you have a time, just participate with their prayer also, they will be happy. And I like that Dr. Murali is here and we participate in so many prayer groups. And then the third question regarding the rehabilitation strategies, which remission comes, then the relapse comes. There, the problem is that regarding the continuity of the medication, that is still a very difficult thing to manage in our culture. Because most of the people, usually even in Kerala, we can see that the people always say, oh, you are giving psychiatric medication, that will spoil your kidney and liver, everything. That's a very bad thing, very poisonous thing. Don't give psychiatric medication. These types of comments usually prevents people from taking regular medication. Though their comments are very strong. And to overcome this thing, we used to have a very good family education system and support, family support. And regarding the another one is about the media, which you asked. It's a very correct thing. You see, if you go to the press council rules, there are strict stipulations, but nobody follows that. There especially says that in a suicide case, don't publish the photos. And don't make any comments or don't make the pagal usi taraf nahi likha hai sab isme bolta hai. So don't involve, don't make any comments on madmen, and even in movies, don't pass any insulting comments to the patients. Such things are the rules are there, but you know, the media they goes on their own way, and we are taking some initiatives in that aspect. As I think IPS is also taking some initiatives in that aspect. In Kerala also, in the local media, we are trying to do some things, and we are giving some awards in IPS Kerala. We are giving in some awards for the best feature about mental illness for every year. And also for TV, we are having an award system for that. I like that. Some work with them and involve with them and make them more cordial with these things, and make them understand that this is a problem and nobody is there to help these helpless people. And that's our human concern is there in most of the people. And we have to click there. Then you will get the right result. Thank you. Thank you very much for the question. Yeah, Dr. Murali.
Murli sir.
Yeah, I think Dr. Sharma's first question is interestingly addressed by the World Health Organization from 2017. There is a program which is called the Rehabilitation 2030, a call for action. And in that, to achieve these goals of to cover all the people of all disabilities with a rehabilitation program, the thrust is to include this as part of the healthcare system. And third initiative, third point of the 10 programs which they have mentioned, one is that improving integration of rehabilitation into the health sector and strengthening intersectoral links to effectively and efficiently meet the population needs. And all the countries which are part of the WHO over a period of time may have to align with this. So that's a big hope which is going to come, because this also will help to patients to get insurance. That is one of the biggest problem which is happening for rehabilitation, because insurance is an issue. And they do not want to give insurance for a pre-existing condition. All those things will get addressed with this. And the target period was to be 2030, but I am not very sure whether this will be achieved because of this precious few years of COVID and throwing new challenges. And globally, there are a lot of new challenges have come up, recession. Of course, I don't want to say conflicts, declared and undeclared conflicts. And so that's the way it is going to take time. And I was attending this program as a member of this thing from 2017 because of the WAPR. Interestingly, the only one mental health representative is was me alone in this particular program. So basically, even at a larger level, when you talk about rehabilitation, people still think that rehabilitation is only for people with visible disabilities. That is, psychiatric disability is invisible. So a walking, talking patient has come. Why you want to rehabilitate? When a person is having blindness, when a person is having deafness, person cannot walk, because locomotor disability covers almost 63% of the disability, and which of course is a much more sympathy generating rather than a chronic illness which goes on for a long time, developing disability which has to be addressed. And we have to teach the secretaries. There is a time where Radhakrishnan will remember that we have to teach the government people to tell that what is a disability in psychiatry. So unless we are able to communicate that way the government understands, we are going to have this challenge to continue over and over. So there's no need to discover a wheel over and over. And I'm so happy that our past secretary of WAPR, Solomon Ratnamani, is also attending. One of the things which comes in this is that there is a lot of rehabilitation happening in low and middle income countries, which are not getting published because of the so-called publishing standards of the evidence base. Now, I would like to recollect Dr. Goyal, our former advisor, and now currently in New Zealand. In one of the meetings, he told that what we are listening and reading from the literature is not what we are seeing there. And India is much more ahead in rehabilitation than various other places, because in India, majority of the rehabilitation program are going on with the non-governmental organization with a big community participation. So I think I have addressed few things. I don't want to continue for a longer time. Thank you very much for giving this opportunity to talk to all of you.
Thank you, Dr. Murali. Especially, I would like to recall Dr. Murali's involvement in ideas I told you earlier during my presentation. And another thing is also I want to mention, as Dr. Murali is here, I would like to tell that because when this disability rule came into the formation, there was a lot of resistance from other areas, not including mental illness in the disability rules. And Dr. Murali's and Dr. Mohanai said their intervention and involvement with Dr. Gauri Devi, the NIMHANS fought for that. I like that it was included as the last one, mental illness. So that appreciation goes to Dr. Murali and his team during that time. Thank you. Welcome, Solomon. Thank you very much for attending this program from South Africa. He was the past Secretary General of WAPR and doing a lot of work in South Africa regarding the rehabilitation.
He is regular in Trust Musings.
We can hear it.
Dr. Solomon Ratnamani. Hey, good evening.
Good evening.
Sir, a question from my side.
Yeah.
Since you are a Secretary General of WAPR, regarding the worldwide standing, how are other countries doing? How are we doing in this field?
Regarding rehabilitation,
Yeah.
and as Dr. Murali mentioned, India is doing a lot of things. Especially the low-cost rehabilitation is our Indian concept. And if you go to the different states of India, everywhere they are doing some innovative methods in rehabilitation. Even in Orissa, Dr. Thopanpati is doing so many things. And Calcutta, Assam, again in Lucknow, then Rajasthan and Gujarat. Dr. Suvalka is there in Gujarat, is doing a lot of things. And so many Maharashtra also, there are a lot of rehabilitation works are going on. To some is not get published properly, but they are doing. And the rehabilitation standard as at present, if you take a worldwide assessment, India is in a very high position now. And we have to regularize so many things. There are so many legal issues are there. We are working on it.
How is a high income country and a low-income country, what is the difference in rehab models there?
Yeah, in high-income countries, it is they are using a more sophisticated methods. In low-income countries, and just making puppet daily, that's a rehabilitation program. In Dr. Shivakumar and Nimmans, they planned a program. They were collecting the used flowers from temples, and they dried it and make powder of that. They used in holy. There's so many things which they are doing regularly in our places. Some wonderful innovations are there. When Murali and myself visited in Marayu, we have seen a place where they are making they are getting rubbles and making it small chips and selling it. And in Calicut, there's a program, there's a pickle unit. They are making a separate type of pickle only popular in Calicut. That's Kalumek, a small type of modules from sea. And they are making that pickles and with a great demand. If you want to get a bottle, you have to book 3 months back. Like that. So they are having a different program. We are having a different program. But still, rehabilitation is taking place in all these aspects.
Okay, thank you, sir. Dr. Solomon is there. If he wants to comment, please.
Soli.
Yes. Thank you very much.
We like to hear you.
Thank you very much. Can you hear me now?
Yeah.
Yes, sir.
Yes. Yeah, I was just saying, first of all, VK really presented a very comprehensive approach to psychosocial rehabilitation, and I'm glad that Murali was there to support him. We do have an issue in terms of points of engagement. Low-income countries are not the same as high-income countries. You know, to give an example with a different concept, not psychosocial rehabilitation, when you talk about task shifting, that seems to be applying to low-income countries and middle-income countries, but you don't find it in high-income countries because they have all the resources. So you'll find that there's a difference in resource allocation in low-income countries. For instance, South Africa has both the rich and the poor world. Generally, the split is still there. So you find that in the big cities of South Africa, our approach to psychosocial rehabilitation is too sophisticated. You know, it's like we're in London, we're like in Rome or whatever. But when you go to the deep rural areas, you know, models are different. And we piggyback it from the examples that VK talked about in India. So India is still leading, and based on our experiences in terms of how these things are presented at our regional and meetings and congresses of the World Association for Psychosocial Rehabilitation, I find that the model that India follows is very clear, it's very practical. People are committed, they're in the community. Just to give an example, our incoming president for World Association is from Milan in Italy. But the approach in Milan, it's very sophisticated because they have family support groups that are well supported financially, and they can reach out to patients in the communities, even more than maybe most of us in certain low-income country areas can do. But I think South Africa shares a lot with India for the majority of the patients that we see. So thank you very much, Viken. Thank you, Murali.
Thank you, sir, for your comments. Amrit, you want to take over?
Dr. Murali, you want to speak something? Yes, raised his hand.
Now, one of the question which is asked about is the difference between low-income countries and middle-income countries. I would like to say one more step, because Soli had mentioned a few things, and we also have Manal Eliva from Egypt also attending this. And interestingly, I would like to refine it a little more in terms of the English-speaking countries and the non-English speaking. See, for example, the rehabilitation in Germany is something very, very a good eye-opener. We do not get the information because of the language. Similarly, in Spain, a lot of things are being influenced by the American influence, But I would like to say in this forum that there is some amount of English hegemony. I used the term hegemony because we are not having access to these other methods. So there is a possibility that I'm working on a possibility that we will be able to provide some fellowships in India where people can be trained on rehabilitation, as what Radhakrishnan was talking about, where people can have a hands-on experience. And one of the dream is to see that a large number of psychiatrists and mental health professionals in India will be trained. And I'm trying to work on that particular possibility, either through WAPR as well as through the IPS, so that we will have a group which can train people in various places. And as a prelude to that, I'll tell you, we have started initiating from yesterday. I have been having a very intense interaction with Tezpur Institute, LGV Institute in Tezpur, to cover the whole northeastern states and see how it could be done and how that can be the best, one of the centers, best practicing centers. Now, our incoming president, who is the president-elect, is actually Marian Farkas from Boston University. They're running a very sophisticated program with a diploma and issues like that from Boston University. Similarly, there are a lot of other programs. Now, as Soli pointed out, there are programs even happening in Africa. The low and middle income countries, the most important difference is that the community resources are being utilized not from a government point of view. And we also compromise on the rights of the mentally ill, which has come as a major thing with the WHO now as a quality rights. And we rely a lot on the family and the community togetherness, which is not going to be there if this rights-based Mental Health Care Act, as well as if you really follow the act, it's very difficult. And similar thing is that WHO quality rights. So the thing, I think Soli also had undergone the training. I have finished the training. What is happening is that it is very, very difficult if you look at a pure Western system to continue with the program. So I think this is an important issue which has come up. People can discuss about it.
Sir,
Sure, sir.
one question I wanted to ask, and that's also in the chat box. So rehabilitation in psychiatry, we generally refer to the rehabilitation in terms of schizophrenia. What about rehabilitation in, substance abuse? I think because we have run a project in Odisha currently, and which has been very successful. Sir. Maybe I'll discuss it later on. But what about rehabilitation in substance abuse disorders?
So it's a very important things to be addressed. That's one of the great problem which we're facing in our country nowadays, because there is a separate rehabilitation program for substance abuses and ganjas, then alcohol abuses. Or in every psychiatric illness, there is a role of rehabilitation. So there are separate.
But if you look at schizophrenia versus people who are having behavioral issues due to addiction, maybe 110 more people are in addiction, rehabilitation centers because of addiction-related problems. And many of these schizophrenics or people having serious mental illness are in rehabilitation centers which are designed for substance abuse patients, and they're being kept.
No, we have separate centers.
What happens that the reality, what we think is in pen and paper and what is happening are two different issues. A lot of rehabilitation centers run on chronic mental ill patients who are kept there.
Yeah, but
the family members are not able to take care of them. The parents are dead, one brother is not able to take care. So how can we design such centers, or what?
In Kerala, we have separated centers designed for these things. And
Kerala is a role model for everything, sir. It's not the rule. It is an exceptional state. So let's.
Yeah, but if I may just chip in here, that is why the concept of dual diagnosis has come in, where you have to look at the main mental illness such as schizophrenia or bipolar mood disorder and associated substance abuse. For instance, we know that many of the bipolar mood disorder patients are addicted to alcohol, and the schizophrenic patients, a lot of them, it's alcohol and cannabis. You have to treat both simultaneously. And that is why in many facilities, when you do rehabilitation, it's not just for the identified mental illness, but also for the associated addiction. So it's very comprehensive. So in South Africa, with 9 provinces, we have facilities in each of the provinces where we trained social workers, counselors in basic methods of intervention. But in that, we're asking them not to focus on the substance of abuse only, but to assess, for instance, for associated depression, anxiety, and if a patient has psychotic features, they must refer appropriately. So it cannot be separated, but you find that for purposes of management, you may find that patients are in one complex and it appears as though, there is no separation. The practitioners must understand the dual existence of substance use and mental illness. Thank you.
Thank you so much, sir. Thank you so much. Sir, there is a question in the chat box also regarding marriage and mental illness. So, whether they should marry, whether they should not marry, whether they should disclose before marrying, because a patient says that if you disclose, how will someone accept the proposal? So, question to the chairperson: what are your views and experiences regarding this topic?
Well, I think it's very commonly we are seeing, people say that now the person, there are many myths as well. People say that, after marriage, things will be better. That's one aspect. Other aspect is what we are seeing on daily basis is that, like, a chronic illness is there, like maybe schizophrenia, bipolar, whatever. The patient's family says that what we will say to the other party. Sometimes they say we won't say and we just marry. Another time they say we will just tell that the patient is having a certain small anxiety and headache, and then that will be sufficient to tell. So it's an issue which is always there, and it's a difficulty for them as well, and it's for us as well how to communicate properly. So I think sir can tell in a better way.
The thing is that it's almost well addressed in our new Mental Health Care Act. So there the definition, the patient care, they mentioned that previously, if there is a history of psychiatric illness, cannot be termed as mentally ill. So the question of the marriage and bipolar is okay there. And regarding schizophrenia, if the patient improves well and if he wants to marry, this is right. We cannot prevent them. There's a lot of questions are there. That Murali was telling about this WHO issues also. The chapter 5 specially mentioned about the rights of the people. And there we cannot prevent if they are interested in marriage. As per the rule.
Yes, but there is the significance in counseling, including genetic counseling, which the family has to be informed about, so that they must know that there are certain possibilities, high possibility of children having the same problem and so on and so on. Are they willing to take that risk? Are they willing to support, the particular couple and their children? Should they have the same illness? It's not automatic that the children will have the same illness, but for in case that happens, are the two families prepared to help them? The greatest answer is the agreement between the two families that are coming together, not just the two individuals.
I had a patient some 3 decades back. A schizophrenic patient came to me to ask about the marriage. Then I told you are suffering from schizophrenia. Now you are not supposed to get married, and there are so many problems like that. And recently, some few years back, just before the COVID, he came to me with his son. He got married, and now his son is doing PG training in UK. He's a doctor. Wow. He's doing MRCP training in UK. Then
so you owe that patient something. Maybe they should sue you.
Sir, I want to ask a question, sir, regarding this. Today I had a case. I had a patient's guardians who came. Was married 4 months back. She developed mental illness 3 days after the marriage. Now this husband's people want a divorce, and finally there was a panchayat where the decision was that if the psychiatrist tells that the patient can get okay, he'll get cured, then the marriage will continue. If the psychiatrist tells that this patient is not curable, then we will not. So the psychiatrist unfortunately is me. So it was a decision of the panchayat that I have to tell that whether the patient will get cured or not. So I have asked them for 3 months time that I am currently busy. In that time, I am starting little intensive treatment. And if I see some, there's a negative schizophrenia somewhere, patient was on treatment before, not with me, but I can't comment whether until unless we don't know, we can't comment. So what do we do in such situations where the dagger is on you? This way, that way, you're going to be damned. So what do you do?
There also the answer is there in Mental Health Care Act. Amit Padjoshi, I know him very well. He's a very well accepted person in that local area. And whatever you says, they believe it. Okay. Then regarding the previous episode of mental illness, cannot prevent them from marriage. That's okay. The present episode, and as you told, you can try for 3 months. Then you can see how the patient improves. And then you can explain to them the details. And once Amrit Padjoshi tells something, the people believes that in that area. No doubt.
Actually, there's a point called incurable mental illness. That is a ground for divorce.
Yeah.
Any mental illness, here we give, as per ideas, only for 5 years only we give disability. It is a temporary in nature for any kind of mental illness. And second point is the illness started only after marriage. So here there is no question that the panchayat should interfere like this. And we cannot also say that
the boys' party is telling that she was already sick because it started 2 days after the marriage. So must be on medication. So there is something which we can't prove. This way, that way,
No, basically in mental retardation, if a patient comes just before Jagannath and Navakalevara, so many people came for divorce cases. At that time, what we said that yes, only if a person is having mental retardation, then that person doesn't understand the significance of marriage, what is the role and responsibility. In that case, the marriage can be null and void. But otherwise, if the honorable court decides that this and with our report that this is incurable mental illness, then only the divorce can be awarded. Otherwise, no.
Alim, we'll have a topic on marriage and this later on.
I think so.
Amrit, I have a suggestion on this rehabilitation. What we are trying actually, sir, I am working in grassroots level. There is a scheme in Government of India that is called Mahatma Gandhi National Rural Employment Guarantee Act 2005. Actually, as per the act, a person who is unemployed should get at least 100 days of wages, and the specific government, it is the responsibility of the government to provide the work to those people.
Amen.
That's there in Kerala.
All over India. So actually, many times I have given in writing to the concerned block development authority that this person has already recovered and some unskilled, he can work as an unskilled labor or unskilled work can be done by him. But many times what I see, although in spite of my writing with my stamp, my registration number, being into a proper government institution also, the other institution doesn't take it seriously. So in national policy, if we, you eminent people are there, if we make some rule that these to be obviously to be taken up by the other agencies, and as you said, rehabilitation should start from day one. My policy is we should rehabilitate at home. Not only by homeless, mentally ill, we will make a center. By that, how many centers we will make? Rather, if we do something like this, then at home only rehabilitation can start. And the disability of one person will not lead to disability of the family members, because they are always guarding that person. And because of him, the other person who is not disabled, he is not able to go to any other place for work. Number two is, regularly we have a course called B.Ed in Special Education. Now these people are special educators who are posted in every block area, but mostly their activities, their expertise in the field of special education is being misutilized. If we utilize their services in the block area, in the rural area, then obviously some rehabilitation can start at their level. And third thing, there should be a mandate also, there should be a target, that we have given disability certificate to so many people, and also it is for a temporary period. How many of them are made able with our effective treatment and effective rehabilitation acts by different departments like SSCPD, like social justice, like health and welfare, so that probably in future something can come up. This is my suggestion. You
Good
can
suggestions. In Kerala, we have conducted a training program for the Panchayat members, Grama Panchayat members, some two years back, just before the COVID. And we were able to complete 70% of the Panchayats in Kerala. And then they started giving the disability pension to the mentally ill people. That was denied earlier. And we made it clear to them that there is a provision in Panchayat Raj Act for the disability pension. The psychiatric patient is eligible. As per the ideas, we have to give a certificate. With that, they are getting disability pension. Now, in last 2 years, even during the COVID days, that is improved, and now more than 85% of the panchayats is granting pension for the mentally ill people, which is sufficient for them for buying their medication and all these things. I think that can be replicated in different parts of the country.
Right.
Thank you very much for the suggestion.
Alim,
Yes, Tufan sir.
take-
So there has been a lot of discussion and many interesting points. I felt like chipping in at every point, because this has been, rehabilitation has been very dear to me since I started my career as a psychiatrist, and Dr. Radhakrishnan knows that. And I have taken different innovative methods myself, and with my small institute that I had with Dr. S.K. Das. Some points I want to make clear what is typical of India. Number one, there is a very large population. Population being large, the mentally ill patient are necessarily schizophrenia, as Amit pointed out, addiction disorders, the people who are being cornered because of some reason or other, they need help. And in this background, multiply with the treatment gap. There is a big treatment gap. So there are people who deserve attention for rehabilitation on first consultation. And there are persons who do not come for consultation at all. I started my work with those persons only, that picking up that persons with police aid and keeping them. And that was a big story I can narrate later on. So, and next important in Odisha is the cultural diversity. Whether we argue for or against, that is totally different. But the cultural aspects, including the spiritual aspects, including the religious aspects, we cannot rule it out. In 1980s in Nepal, they attempted to implement family planning program through the faith healers. So that is essential. If a person in a particular area, there was a study in Chhattisgarh, most of the patients went to the faith healers first. If we intervene at that point, then we are going to reach out. We cannot ignore everyone. All are our partners. And as in Kerala, first partners should be the government. It is quite creditable that in Kerala, they have been able to utilize the government machinery to a large extent, and that should be done in all states so that the government part is there. But culturally, you have to involve the community. As Dr. Radhakrishnan, I had visited for a week many rehab centers in Kerala on my own interest. And what I found, the places where there is community support, community accepted that this is a responsibility for them, and community accepted it in the background that this is going to benefit them. Not as giving arms, enjoying participating in the rehab programs and having at least one dedicated work. That helped, and I was very much astounded. I have seen good centers, I have seen moderate centers. I have not seen at all a bad center with Dr. Radhakrishnan. We have traveled in the night, in jungle. It was a very memorable journey in my life. I shall remember forever. But these are the parts. Community has to be involved. We cannot impose anything, and we have to be interested. The last part Dr. Radhakrishnan told about, you have to spare 5 minutes, not 5 minutes, you have to spare 15 minutes every day to take up a single case individually. You calculate after 2 years, there will be at least 15 persons who have been radically rehabilitated by your personal efforts. That will integrate. Seeing the treatment gap, I am not seeing any psychiatrist, practicing psychiatrist who is not seeing less than 40 to 50 cases every day. If we go as a consultant to a rehab center, it is for a respectful visit for 1 or 2 hours in a week or month, and that is nothing. But patient has to be reached, the family has to be reached. You can do one-to-one. You can help in planning of the rehab centers. All these things are required. What we can do collectively, how to establish center, and how to reach out one. And about the last part, which is interesting about marriage, my taken is that any person who wants to get married and has a partner, we don't have any right to deny. That right is, and it is forms our duty to speak them the truth. What I usually do, I tell that you reveal the truth. Then they told they won't agree. You bring to them, I shall explain that this person has improved and you will, this is the prospect, but we cannot guarantee. Nothing can be guaranteed. After 5 years of marriage, having 2 children, if a person becomes mentally ill, what you are going to do with it? You can explain in that way. You are not going to dump. So being mentally ill should not hinder, but that is the public sentiment. One has to educate it. Maybe if you start educating now, you will be successful after some years, but this is the right path. Thank you very much. And
our great teacher, our great teacher, Dr. Mohan Isaac is there.
Yes, I am going to request him to have a few words.
Yeah, our great teacher, Dr. Mohan Isaac, who taught me psychiatry, is here in this session. I consider it as a great honor, sir. Dr. Mohan Isaac is here.
Mohan sir, you're not audible.
I think your audio has not been. Yes, you can unmute now and speak. Unmute, sir.
Sir, unmute, please. Mohan sir,
Not audible.
Unmute, sir.
Mohan sir, you're on mute mode. Please unmute.
Sir is not audible.
Sir, you're unmuted, but your sound is not yet coming.
Unfortunately, we are not able to hear you, sir.
Sir, are you using a headphone? You can, if you are using a headphone, maybe there is a disc. You can take out everything and speak directly in a mic. That will be better.
That works many times.
Yeah.
Sir, unmute, sir. Unmute, sir. नहीं हो पा रहा. Sir, last try, sir.
Sir, you go to the audio setup, you can do it there. Or you can take out, plug out the earphone and headphone if you have any and speak directly into the mobile phone or the laptop. That will also help.
Even if he unmutes, his sound is not coming.
So that means there is a discord
Can you
between the
hear me?
connection.
Yes,
Now
sir.
we can hear.
Now we
Okay.
can.
Good, sir. Good, good.
I'm so sorry keeping you all waiting. I didn't know what was happening. I was unmuting, but anyway, what I just wanted to tell you, Dr. Radhakrishnan, was that I sent a message in the chat box that listening to your talk was, for me at least, going down a trip down memory lane. Lots of photographs of various programs, lots of friends. Dr. Goyal, Dr. Goyal recently wrote to me that he's becoming an, what is that? Octogenarian. He is reaching 80 years and he is looking very young. So this means that it's a photograph taken many years ago. I saw Johnny, I saw Roy, I saw Mohan, a lot of people, including some of the leading politicians of Kerala. Some of them very controversial. I'm referring to Mr. P.C. George. He has been in the news always, but he has been very helpful for the program of rehabilitation of mentally ill. So thank you, Radhakrishnan, for those wonderful photographs. It was indeed like a trip down memory lane. I just want to make a couple of points. This program is very richly and widely attended. As I was looking through who are all attending, of course, Solly was there, he spoke about it. But I saw another friend who didn't show his video. I am referring to Dr. Shakya, whom I know for a long time. He's from Nepal. He's a big professor of psychiatry in one of the leading medical colleges, but I've known him for a long time. He is attending this. And there are several other people. I see a young person, Anish, who is a senior counselor at the Medical Pastoral Association. I saw a little while ago Ravi Shankar Rao, who is in charge of a very, very important, he's a very quiet and modest person, but he runs a wonderful center in Karnataka for wandering mentally ill in a very remote place. Murli knows, Murli is one of the guiding principles. So this has been a very richly attended program. A lot of points have been discussed about various things. Now, very often when you talk about rehabilitation of mentally ill, one of the areas which has been always referred to as a gold standard is in Northern Italy, in Trieste, which is supposed to be one of the World Health Organization. Everywhere they talk about that place, it's a model center. But the thing is, Trieste has been written about. Unfortunately, lots of things which Radhakrishnan talked about has not been so widely written about. Otherwise, it would have been on par with, if not better than, the program. It is sort of the gold standard for community mental health and rehabilitation, etc. So this is wonderful, and many people have made comments about what is the problem in developing countries, resources, etc. But I believe the core issues in any successful rehabilitation program anywhere in the world, high resource countries, low resource countries, are just 3 or 4. One is that patients deserve dignity and respect. If you can provide dignity and respect to your patient, I think you have already taken the first step. Unfortunately, this is something which is, of course, the community doesn't respect them, they're stigmatized, etc. But I do believe that all over the world, even mental health professionals, only give lip service to giving dignity and respect to the patient. In all the programs that, the several photographs of orchestra, of other things, of making pictures, etc., etc. The core is that you are treating your patient with dignity and respect. The second point is, they are people with the various kinds of disabilities. We are talking about, are they incurable for life? Can they get married? Radhakrishnan gave an example of somebody whom Radhakrishnan is, of course, very kind to patients. He said, no, you can't get married. Now that man comes back to him in a way, challenging him and, saying that, look, my son is now a postgraduate trained. I have similar experience, etc., where we have wondered whether he's going to get married, and they come, of course, they're doing well. The other point which I would like to say is, we talked about genetics of schizophrenia. But even today, if you listen to people like Robin Murray and experts in this, what is the genetics that we know of? They are talking about 100+ genes with very, very low, chance of, the role of epigenetics, how some small genes that you may have got, but how it interacts with the environment to actually produce the illness. So genetics of mental illness has actually become more and more complex. So I'm not going to enter that area, but schizophrenia itself is today accepted as not one disease, but multiple diseases. It is true that a small number of them may have poor prognosis. But people who are experts in the field of schizophrenia, such as Asen Jablonski and Robin Murray and all, say schizophrenia. Of course, for purpose of convenience, Kraepelin named a group of illnesses as schizophrenia, and for want of anything better, we're still using it. But it is not one disease, it is multiple diseases. And to say that it has very poor prognosis, you can't get married, you can't do this, no, we'll give you a certificate that it is incurable, etc. I think we are all doing a disservice to people who have their rights. I think Radhakrishnan made that point. To get married is somebody's right. Of course, the families would want to know, will you be able to work, etc., etc. So the other point I would like to make is that in every successful rehabilitation program, they work on what is called as a strengths-based approach. And in all the programs of the pictures that Radhakrishnan showed, they are making pickle, they are making some kind of things. I mean, the singers, when they sang, the so-called normal singers protested. No, we don't want to sing with these mentally ill people. So what did they do? They created an orchestra. I mean, of course, with the help of, supportive mental health professionals such as Murli and Radhakrishnan and all, they created their orchestra. And what did we hear Radhakrishnan say? They have conducted more than 250 plus stage shows. I think in the WPA World Congress in Bangalore, I think Murli got some of them to come and sing, even for the WPA where there was an international audience. So it is strengths-based approach, allowing their freedom, allowing their human rights, and having a respect for them. And the third point is try to create a social fabric where people with mental illness are treated with dignity and they are not renounced. I mean, the many photographs that he showed, there are Roman Catholic archbishops and bishops, there are priests, there are temple priests. I think the first slide was about a temple, and many programs where there are a lot of people from the community trying to integrate and creating a social fabric where mentally ill people are accepted. I mean, these are all the ingredients of a good rehabilitation program. Not whether it is a developed country or a developing country, not whether you have big resources or small resources. The resources will of course help. But I think what is important is treat them with dignity and respect, allow their freedom, have a respect for their human rights, and work on even the most disabled schizophrenic person with schizophrenia will have some strength. Maybe it is to sing. I mean, a lot of these people in the orchestra are people who are good singers. So once you work on a strengths-based approach, I think then you are leading a good, you are working towards a rehabilitation program. I would end here because it's been a wonderful program. I was in India quite recently, but I came away to Australia, and there is a 2.5 hours difference between the Indian time and my time here. Now it is actually, at 12:30 plus. The only reason why I stayed awake is to listen to Dr. Radhakrishnan. And I knew what he would be saying, and I knew some of the program, some of the photographs. I've seen some of them before, but I wanted to see them again. So thank you very much, Dr. Radhakrishnan, for this wonderful talk. And we are so delighted that you're representing all of us as the Secretary General of the World Association of Psychosocial Rehabilitation, and with Murli and Soli and others. We are hoping that lots of things will occur in the developing world, in the so-called third world. Thank you very much, and back to you, the organizers.
I have a note of thanks to Dr. Mohan Isaac. Just 1 minute interference. Thanks for being here, Dr. Mohan Isaac. And I will request you to be here despite the time lag, because you are regular with us and you are inspiration for us. Please be here. We will keep on posting you. And may I inform you that the 100th episode is on July 7th. And we have got Dr. Dinesh Bugra. And we always feel inspired to see you among us and have your valuable inputs. A request.
Thank you.
Please keep awake.
Oh, thank you. very much. Thank you very
If
much.
when I am in Australia, I shall keep awake. Whole night doesn't matter.
Thank you, sir. Thank you very much.
Thank
I
you.
just
Thank
I just want to tell two sentences about the first slide, as you mentioned here. That's a slide of the temple Shabarimala. What's the importance of Shabarimala? Everybody is seen equal, because there the Tattvamasi, the concept is that you are God. So everybody is visiting there is God, equal to God. That's why I put that slide. Everybody is equal. There is no discrimination between the upper class or lower class or caste based. Nothing is there. Everybody is known as Ayappas, Swamis. That's why the first slide was shown. Sir, thank you very much for attending this session, and thank you very much for your nice words. Because all these things happened because of your guidance. Because you molded us in the beginning. Murali, myself, we all were his students. Thank you, sir.
So
May I
I'll
have
give
a just a minute, Amrit? I have a small suggestion. I know I am killing into past pain, but because I get Murli and Radhakrishnan of WPR, can we try to collect all information about the rehab centers and different innovative models, as well as the individual rehabilitation achievements, and keep a record of it? There may not be publications because many people who do work, they don't go in for the publications. And because the methodology is totally has to be compromised looking in the community perspectives. But I think you can initiate. There is a lot of material in India which can be a guide.
Okay.
I will help you.
Okay. Thank you.
Yes, Samrit, please.
So it's a formal thank you. We've had a lot of thank yous, but then I would like to thank Dr. Radhakrishnan. He managed to bring people from Australia, Mohan Isaac sir, Solomon sir from South Africa, we have people from Nepal, we have people connected throughout, rehabilitation, we connected to a lot of people. So it was a brilliant storytelling with a lot of pictures, and you never forgot people whom actually made this happen. Generally, people tend to take the credit themselves, but you gave more credit to others than you took it yourself. Unlike what Alim generally does. He generally takes all the credit for whatever is being done in Thursday Musings. So I would like to thank our chairpersons, Ravi, for asking a lot of questions. Dr. Bibu is an elder brother to me. He works a lot, and he actually spoke like somebody who knows where the loopholes are, where things can be turned around. That's what we need to learn. Laws are there, but how we can, break those laws or work around the laws to help people, that's what Dr. Bibu taught us. Thank you, Dr. Murali. As always, your views are insightful on the spot. Mohan sir waking up till 12:30, 1 o'clock in the night. That's so wonderful. Even though you talked that because Radhakrishnan sir was speaking, you came, but you are generally there in Thursday Musings. So every time we are there till 1 o'clock at night, listening to whatever we are trying to turn out to be. Thank you to all our viewers. Thank you, Dr. Tufan sir. He's a man who is very much interested in rehabilitation, and that's a topic close to his heart and soul. So thank you, sir, for choosing this topic. Thank you, Dr. Alim. You look sunburned all the way from Ladakh. He just joined today from Ladakh, so he's all tired. Even then, he is there. So thank you, Torrent. Thank you, IPS Odisha State Branch, for helping us with all these things. Meet you again next week, another Thursday Musings. That's the 97th episode. It sounds so big, but then we have already reached 96 episodes. So it's all your contribution, your inputs, your insights, and your presence. Thank you. Good night, everybody.
Good night, everybody.
After long, we crossed 10 o'clock.
Thank you. Good night.
Good
Good
night.
night.
Sir.